Yes, hi. So we're going to chat through some of the new advances in osteoporosis management. It's seen a sea of change, and ever since we were medical students, our understanding of osteoporosis has changed at many fronts. And I think I'd like to focus more on what sort of basic fundamental understanding we should have, and then maybe touch upon a bit of treatment. It's a good contemporary approach to osteoporosis. We try to cover the newer outlook at the disease, the diagnosis, the drugs, and the newer surgical interventions, just to touch upon them, since most of you are medical professionals. So coming to current concepts of the disease, I think the big misconception going around in the society is that osteoporosis is equal to calcium deficiency. Really, it is not. It's far from that, actually. And we must understand the difference between bone mineral and bone mass, or bone quantity and bone quality. We'll touch upon that a little later. So calcium at the point of osteoporosis, calcium has very little to do with treating the disease itself. The second thing is that osteoporosis is not is a generalized disease. It is not a localized problem. So as an orthopedic surgeon, I would see a fracture and I would treat it. But really, why this fracture has happened is what needs to be looked into. And the entire set of bones in the body have to be treated. Otherwise, the chances are that this fracture either will not heal, or there'll be another fracture knocking on your door very soon. The third thing is that there's really no treatment for osteoporosis. What we have is prevention, and we can build up our bone profile well in our developing years. And once we have a full-fledged osteoporosis, it becomes hard to actually reverse it. So there are good modalities available now which are trying to push the bar. But really, early diagnosis and treatment is the cornerstone of treating osteoporosis, prevention rather than cure. Coming to the normal structure of the bone, and this is a very simple way of understanding as a surgeon how the bone is created. So the bone has, like any building that you see on the on the streets, it has columns and it has beams, and this crisscross structure is an engineering miracle that holds up the entire system. Enmeshed in this is mineral, and mineral, apart from calcium, has a number of other elements, largely protein, proteoglycans, and calcium, and that creates this density of bone in a basic lattice structure. Okay, it's very simple to understand from this figure. Now, osteomalacia is demineralization of the bone. So the column and the beams, they remain as they are. There is no reduction in that. The basic structure is the same, but the quantity of mineral that went into this goes away, and that's because of a deficiency. So a deficiency of calcium due to a deficiency of vitamin D, added with deficiency of proteins, if you may, leads the bones to weaken quantitatively, but really the base is maintained. While in an osteoporotic bone, there's a loss of actual framework. So in an osteoporotic bone, the quality of the bone itself gets hampered. So this is how it would look on a, on a diagrammatic, where a few columns have gone away, a few beams have gone away, and hence the place where the mineral can sit in goes away. And hence this is a qualitative change where the entire mass of the bone has actually gone down, rather than merely the mineral content which is causing this bone to get dense. Thus, this loss of bone lattice and change in quality of bone leads to a rarefaction of bone, and that is really the colloquial meaning, or the English language meaning, of osteoporosis, where the bone has become porous. And porosity is as you can see in this picture, the lack of the entire framework of the bone, and the mass per volume becomes less. This leads to an inherent collapse, like an implosion of the bone. And it's very, very different. The fractures that you get in osteoporosis are very, very different from the fractures that you commonly hear of. So we talk about this much like if you smash a brick with a hammer, you'll need a lot of resistance, and then the brick will shatter. That is what a conventional fracture is like. In the spine, we call it a burst fracture, which is seen in young adults in major road trauma, etc. But an insufficiency fracture is like a cardboard box collapsing. So the box is empty and you just crushed it in, and it implodes on itself. And this really happens not because of the trauma, but because the bone itself is growing weak. So an old building in Bendi Bazaar is going to just collapse by itself without an earthquake, because the the building material has gone has been around for too long and it's weak now. So it didn't take too much for the building to collapse. That's pretty much like how an insufficiency fracture is. And we must realize this when we treat it, because it's not going to heal like a regular fracture. The repercussions are going to be very different. And of course, if we don't recognize that this is the manifestation of a underlying disease, you're going to ultimately have more and more fractures coming up in the course of the years. The other thing that I would want everyone to understand is this bone turnover cycle, or bone formation, bone loss cycle. All of us have gone through it. There is formation of bone and loss of bone that happens on a continuous basis. Of course, in a child, there's much more formation and much less bone loss, and hence there's growth. In an adult, this roughly remains equal. And as we go older, the bone loss increases, as you can imagine, and the bone formation slowly goes away or starts going down. You see this big fat arrow in a woman that depicts a sudden increase from a 0.5% a year to almost 2 to 3% a year of bone loss after menopause. And that's where women tend to suffer more, because this is a second attack, not just mere aging, but hormonal regression that causes the bone mass to suddenly drop down pretty much against the run of the tide. I mean, the graph suddenly dips in during the wave of menopause, and then eventually it settles down. So women basically are at a risk of very sudden loss of bone strength in the period of menopause, and they may lose actually up to 40% of their peak bone mass by the age of 80 years. Peak bone mass, very simply put, is what you have earned as your bone mass at the time of adulthood. So by the time you're, say, 30 or 35, what bone mass you've achieved through genetics, through nutrition, and through physical activity is what you're going to live off for the rest of your years, if you may. So it's almost as though your bank balance has to be built up before you retire, and your retirement age is 40, and up to 40, whatever bone you can build up is what bone you're going to live off for the rest of your life. And hence the first slide about prevention is to inculcate good habits in children about eating, physical activity, etc., nutrition, so that they can try to edge past the genetic barrier and develop a better bone mass as best as they can before they start, using that bone mass for the rest of their life, so to say. Coming to diagnosis, what are the newer aspects or the modern trends in diagnosis? So really speaking, osteoporosis remains a clinical diagnosis, and as a clinician, you have to look at your subject. An elderly lady who's frail, who's poorly built, with poor muscle mass, who complains of serial weight loss, complains of inertia, generalized pains, maybe a progressive kyphosis. And I mean, these would be the characteristics of a classic osteoporotic lady or osteoporotic patient. Other than that, of course, nowadays we find a few young men. Every year I must treat 3 or 4 such people who are young, apparently healthy men who have pains and aches, which unfortunately emanate from the spine, and that's how they land up with a spine surgeon, because the spine seems to be loaded for the most part of the day as against the rest of the body. So young men coming with undiagnosable back pain, you hazard a guess and look for osteoporotic values, and you find that they are in the lower than -2 range, and you treat them, and they really are grateful because their pains go away. And until now they were being treated, and these are not osteomalacics, these are osteoporotics, because their vitamin D, etc., remains normal. The source of this problem could have been testosterone deficiency, or could have been a chronic vitamin D deficiency. They present as osteoporotics. Having said that our typical subject is this elderly lady who comes with progressive kyphosis, and the tests that we do for them typically is the DEXA. And I think all of you must be prescribing this a lot. Dual energy X-ray absorptiometry. You must remember DEXA is very different from the sonography of the heel and a quantitative CT, which is done at many places. The DEXA has become popular because it's the only quantification, an objective value that is given to osteoporosis, number one. And we like to have a value, a number, rather than a descriptive name. The other is that the DEXA is the only standardized tool. So a QCT or a quantitative CT actually gives a much better definition of mass for volume of the bone, but we don't have standardization. So a -2 on a QCT doesn't really make as much sense to the clinician as a -2 on the DEXA does, because there's a better better understanding, because there are better normal values and better denominators for this value. It's a screening test, and it compares T scores and Z scores, which compare age-matched and normal healthy populations. The WHO defines osteoporosis as less than -2.5 values on the DEXA. But of course, there are several limitations, as you can imagine. It's oversimplifying this pretty complex disease. The sensitivity of the WHO definition is pretty poor, and it does not cover for so many other, other things that are things other than the DEXA: population variance, extraskeletal risk fractures, and of course qualitative bone changes. Just to give you an example, if you have eaten a calcium tablet and it's hanging around in your stomach, and you go and get a DEXA, that calcium tablet will be interpreted as good bone mass, because the DEXA cannot identify bone from that calcium tablet, and etc. So there are too many. If you take the the osteophytes, which are sclerotic, that may falsely make your bone density look better. So DEXA is merely one tool which should be seen in this entire mass or entire largesse of age, genesis, genetics. Like in India, Parsis are at a much higher risk genetically for osteoporosis. Ethnicity, medications that the person is on, his general profile. So a number of factors: family history, premature menopause, deficiencies of hormones, the hyperthyroidism. So a number of risk factors that have to be colluded. And to make things easy for us, there's this FRAX tool, or the Fracture Risk Assessment Score tool, which the WHO has finally given. And that's an online tool which is available to all of us, and it's country specific. So I'd encourage you to go and look it up for our country. And if you put in all the parameters for your patient, you would find that DEXA is merely one of so many parameters. And it's really not the only thing that they're hanging their hat on. But it gives you a rough risk assessment of fracture in the next 10 years for this patient. So it's a good tool to go by. Really speaking, we don't use this for every patient, but the more you use it, the more insight you get on diagnosing a patient across the table when you have to talk to him and try and figure out what he has or whether he's osteoporotic or not. So there are several occasions when the DEXA does not look so bad, but still hazard on anti-osteoporotic treatment, and vice versa. So I'd encourage everyone to look into this DEXA, this FRAX tool, mainly to gain insight rather than specifically use it on on every patient. There are tons of new lab investigations available other than the DEXA. So these are blood and urine tests, of which the ones that we use typically are these three: the bone formation markers and the bone resorption markers. So what role do these have in my clinical practice, which should be in your clinical practice also? So when you want to take a decision on whether you want to give this person anabolic agents, which are going to increase the bone strength, versus anti-resorptives, which are going to reduce the rate of bone loss, these tests will give you an insight on what to use when. So bone formation markers, if they are high, it means the bone is trying to form, but the resorption is probably higher. On the other hand, if bone formation markers are low, he probably needs an anabolic agent to increase the strength of the bone. So the example we give is that your bone is like a bucket of water, and there's a tap that's filling it and there's a hole that's leaking it. If the hole is big, there's no sense in increasing the strength of the tap. You want to first patch the hole, and that's equal to anti-resorptive agents. While if the hole is not leaking as much and the tap is running slow, you want to increase the strength of the tap, which are bone forming agents, and that treatment would be better. So basically, in short, if P1NP is high, then you mostly give these patients bisphosphonates. If CTX, NTX are high, you mostly give them bisphosphonates, and vice versa. If P1NP is low, CTX, NTX are low, we would rather give them teriparatide. That's a rough, very simplified bottom line. But we do use these in more difficult osteoporosis patients. So coming to a quick view on the current concepts of the drugs used in osteoporosis. Really speaking, HRT, calcitonin, bisphosphonates, and parathyroid hormone are the real running drugs, the chalu drugs. That's what we've been using in clinical practice. HRT has gone away because of some reasonably good trials that showed that the side effects of HRT in postmenopausal women, that's hormone replacement therapy, estrogen therapy, which was very popular 2 decades ago, it's really gone away from clinical practice because so many patients in the trial of HRT developed cancers, breast and cervical cancers, that the trial had to be stopped. So clearly today giving HRT as a treatment modality for osteoporosis is, I think, out of bounds, and I'd encourage all of us to not use it. The calcitonin nasal spray, a lot of good and bad press on this, but it's an anti-osteoclastic agent, and hence it works in osteoporosis. The good thing is that it has a great analgesic property, so it works. The patient feels that it's working very fast. The bad thing is that being an antigen, it's salmon calcitonin, an antigenic substance from salmon fish. So the body quickly develops antibodies to it, and hence a resistance to it, and hence it cannot be used for longer than a few weeks. So in practice, we like to use this in acute osteoporotic fractures which are painful to start off proceedings of treatment, and then follow it up, or simultaneously start with our mainstream treatment, which will take shape a little later. So in an osteoporotic fracture, vertebral fracture with pain, this is a good treatment to, for the first month or so, and then you pull it back off, and most patients are happy with this. The other, or the mainstay of treatment, seems to be bisphosphonates. Now, bisphosphonates are medicines that reduce the rate of bone loss. So what are we talking about? You already have bad bone, and all that you're doing is that you're giving a medicine that is reducing the further worsening, or slowing down, not even stopping, slowing down further worsening of this bone. So it's really a negative kind of approach to treatment. Yet this is the mainstream treatment that we use in practice because it's a well tried and tested drug. It's easy to administer, one tablet a week. That's it. So very easy to administer. Now there are many forms of of this drug, and it's inexpensive. And most importantly, this is the only drug that can be practically given lifelong. It can be used for a very, very long period of time. Newer drugs that have come, which we'll subsequently talk about, have a limitation in that because they're newer. Their FDA profiling is still, in transit. It's still work in progress, and it will happen as the years go. So bisphosphonates are a good startup drug in postmenopausal osteoporosis. As you understand that they reduce the rate of bone loss, and hence they should be best used when the bone mass is not that bad. When it's really rock bottom, doing this is doing too little too late. On the other hand, teriparatide, which is the wonder drug, which which is in the market today, it can actually induce bone formation. So a few years ago, it was improbable that we can have a drug that can actually U-turn osteoporosis. But this drug has come out, and there's enough literature, enough proof that teriparatide or parathyroid hormone in small doses can actually increase bone formation. And when you think of it as a clinician head-on, bisphosphonate versus teriparatide, how do they act? So bisphosphonates will reduce the rate of bone loss, as we said, while so on a preserved lattice. So this is the lattice of the bone. It will stop the lattice from getting weaker, and on top of this, more mineral will develop. So in a way, it produces denser but different bone. It does not produce more normal bone, and this bone is hard but brittle, and hence the DEXA would improve, but necessarily we would not get an improvement in quality of the bone. I think that's a given because the bone lattice framework that has gone away in the osteoporosis has not been turned around. And hence it's best used when the lattice is not grossly weak, so DEXA between -2 and -3 may be a rough indicator. On the other hand, teriparatide actually stimulates bone formation, so it creates new columns and bones, as you can see on this pictorial. And this dense column and bone structure, a denser column and bone structure, is better filled by the mineral, and that gives you more normal bone, and of course better density of the bone. And the bone quality can actually improve with teriparatide, and we use it normally. Of course, I mean, common sensibly, this should be used for all patients because everyone's going to benefit. This is the only positive treatment. The problem is that teriparatide can be currently by FDA's approval rates, it can be used only for 30 months in your entire lifetime. So 2.5 years is the maximum you have. It's like a power play. You got to use it at when you really need it, like an ace of spades. So we tend to use it when it's really needed. So we like to push the indications to higher level osteoporosis. So common sensibly, everyone would benefit with this. Of course, if you've had a history of cancer, teriparatide is contraindicated, and there are a few more contraindications. You got to check PTH levels, check calcium levels, check P1NP levels, and then start teriparatide, which is a very basic startup kit, so to say. But once on teriparatide, the improvement is almost everyone benefits with it. Coming quickly to some slides about what are the treatment options that we as surgeons or as clinicians can offer, and we've had probably the first international publication on this has come from our team, which is on planning surgery for osteoporotic fractures in the vertebrae, an algorithm, though it may not interest the non-practicing spine surgeons in the crowd. It's still worthwhile, to know as a general knowledge. We normally would reserve intervention. I've written surgery, but it's really intervention when conservative treatment has failed. So there's an osteoporotic fracture in the spine and it's not healing. When there's progressive kyphosis, when there's neurology, and when you want an early start out from, you don't want this guy to be in bed for too long, we use interventions. Normally, we must understand that insufficiency fractures don't necessarily heal. About 70% of them do heal, and they do heal, but they heal with collapse and deformity, which in that age group does not matter much. So most patients get on with their life. But again, we have a publication in the European Spine Journal on predictors of kyphotic deformity in osteoporotic vertebral compression fractures. So from day one, we knew that this fracture was going to collapse and heal with significant kyphosis, we would probably want to treat him preemptively, because treating the fracture after the kyphosis has happened can be a fairly challenging task in this group of old, patients with comorbidities. Many fractures don't heal. So about 30% of fractures go into pseudoarthrosis or non-healing. And this kind of cavity that you can see in these x-rays, it's called a Kummel lesion. And it's described as avascular necrosis of the vertebral body. And it's a very new term which was defined just late in the last millennium by Japanese authors. But now all of us understand that once you see a cavity like this, which looks pitch black on the x-ray, which shows an opening, closing on sitting and lying down x-rays like an alligator jaw, and looks white in color on MRI because it's full of fluid, this practically takes away all chances of healing there, because this is like a synovial fluid cavity, and this remains a pseudoarthrosis forever. The chances of this healing are very, very low. And when this happens, like you can see in this case, you can see that cleft there, and there's no cleft when the person stands up or when the person sits up. But on lying down, the cleft opens up like an alligator jaw. These guys would do well with just injecting cement inside. And common sense tells you that if there's a cleft there or a cavity, you just pack it with cement, and you can get a very easy non-surgical local anesthesia, almost outpatient treatment for a pretty symptomatic condition. So vertebroplasty, and this gained a lot of popularity in the first decade of this millennium, and everyone started doing it. We were doing it, left, right, and center, but we were forgetting the bottom line, and the bottom line was there. Osteoporosis in the red zone is really your enemy, and here you're putting a Ferrari engine in a Fiat car. So you're actually putting in a blob of cement, which is so hard in a set of very poor bones. And this kind of unrestricted use of vertebroplasty, because of good results, started showing up newer problems as the patients started growing older from their vertebroplasty, and we started seeing a number of issues with vertebroplasty, and realized that it's not treatment, but it's a time buying option, and you still have to back it up with anti-osteoporotic treatment. For example, you cannot use vertebroplasty when there's neural encroachment, clearly. But more importantly, non-contained fractures, and a big bunch of our osteoporotic fractures have their end plates fractured. If that has happened, if you put in cement, the cement is going to leak out, and that leakage will give rise to big problems, like you see in this case, which we started off seeing. The cleft in the bone, Kummel lesion, cemented. The patient did very well, but in 3 or 4 or 6 months, he comes back with this kind of a crumbling of the bone around it, as you can imagine. You can see on this new MRI, the adjacent bone also is being eaten up, because it's like an eggshell of bone, and you've packed it in with really hard material, which is cement, and over time the whole thing collapses. And this then leads to a much bigger posterior stabilization surgery, because the bottom line is treating osteoporosis. Yeah. So when a patient with an osteoporotic fracture with the end plates destroyed comes in, they really on day one need a fairly complex reconstructive surgery rather than vertebroplasty. Also, if the fractures are close to the end plates, but the end plates are intact, there are chances of having covert leaks like you see here. And these covert leaks cause disc space invasion, and hence the vertebroplasty fails. Of course, people with kyphotic deformities, a blob of cement cannot create an improvement in their kyphosis. When instability is a lot, you can't do vertebroplasty. And if there's pre-existing adjacent pathology, so these are more technical issues, like this gentleman with a lumbar stenosis, or this lady who had an osteoporotic fracture but a significant lumbar stenosis, that you can see here. She doesn't need a vertebroplasty but needs this kind of a procedure where, of course, we power the bone with cement, but we do decompression and a fixation also. And that's what's going to set her up for the rest of her time. And generally high demand back. So we see much, more and more active 70 and 80-year-olds where a vertebroplasty will stand only for a short time. Like this farmer went back to work. He was 69. Excellent result of vertebroplasty. Went back to work, started bending, lifting, overhead lifting, etc. And soon came back with the bone causing erosion, or the cement causing erosion of the adjacent bone. And that can be big trouble. So you basically have to limit your indications and select your case meticulously to offer vertebroplasty. I'll quickly show you some surgical strategies that we use based on our algorithm. Basically, when we do surgery, we want to know whether the person has neurology or does not have neurology, and whether the person has kyphosis or a deformity or does not have a kyphosis. And that's how you structure your surgery. This is just to briefly make you understand. So if there is no neurology, but there is conus or cord compression on the MRI, where vertebroplasty becomes avoidable. You cannot do it. This procedure, which is a mini open vertebroplasty, becomes an elegant method of treatment where you make a small incision, decompress, and do vertebroplasty under vision. And the schematic of this is like this, where you do a posterior surgery, decompress the cord, decompress the indenting part of the bone, and then let the cord expand, and then put in a needle and cement the bone, so you get a structural strength and you can get away without doing major instrumentation. If, however, the person has a neurology, so an osteoporotic fracture with neurology or lower limb deficit, these guys will need a different approach to treatment, and that can mean filling in a cavity or closing the cavity. Like in this case, you have a cavity there, but there's no kyphosis. So all you need to do, this is the case I showed some time back, where you cement the cavity. So you fill the cavity so it doesn't allow for this to collapse in future, and do an instrumentation from behind. But if the patient had an osteoporosis, so if the patient had this kind of a deformity along with an osteoporotic fracture, or this one, for example, we use that cleft to close the cavity and correct the kyphosis. So from a kyphosis, we correct the alignment and the patient becomes straight again. And in a rare group of people where the osteoporotic fracture has open end plates, like we saw in the other case, we do posterior surgery and reconstruct the anterior column. So here's another case where we can get them back to normal, because nothing short of this pretty morbid surgery, nothing short of it is going to help him, and you might as well bite the bullet right up front. Having said that, we are getting smarter and smarter at surgery. Osteoporosis is still a huge challenge to us, and you keep seeing failures of surgeries like this one. And until we get this funda right, that the treatment of the fracture is not what the mandate is, but the mandate is to treat the osteoporosis, every good surgery will also fail. And hence, I'd conclude by saying that to age gracefully, I think be watchful of osteoporosis, try to prevent it in children, try to look for it. The eyes will only see what the mind knows. So you should always suspect osteoporosis in likely candidates. Institute treatment early, so you're not stuck with low bone masses. And most importantly, as a clinician, when a fracture comes to you, if it seems like an osteoporotic fracture, make sure that after you fix the fracture or deal with the fracture, aggressively take care of the entire set of bones, so this person can age gracefully. I'll stop here and thank you for your attention.
Our first question.
Yeah.
Our first question from Abhay. Can genetics predict higher risk of osteoporosis?
Yes, so the answer is yes, because uh, we find a female to female concordance. So from mother to daughter, we find even heredity other than genetics, but the genes are still being identified. So to prevent osteoporosis based on gene therapy, we are still not there. So to answer your question, we know that osteoporosis is heavily a genetic condition, decided genetically, partly hereditary also, so linked to the chromosomes, but we still don't have a method to treat this on the basis of this knowledge.
The second question is, I have heard of hormone replacement therapy. How effective is this in the treatment for osteoporosis?
So hormone replacement therapy is extremely effective because in women, as we discussed, the bone mass is going is slowly going down, and when they attain menopause, there's a sudden drop simply because the estrogens have been taken out of the system, and common sensibly you add estrogens to the system, and the ill effects of menopause should go away. But the problem is that it's not as simple as this. When the estrogens go away, nature has made them go away. It's not a disease. Menopause is not a disease. It's a natural phenomenon. And nature has made it go away because there's a reason that they should not be there in your system at that age. And when we started doing hormone replacement therapy as a logical treatment to this, uh, the incidence of cancer, breast cancer and cervical cancer, both of which are related to high estrogen levels in a older age group, this incidence started growing excessively. And osteoporosis and cancer cannot be matched. Though osteoporosis is a high nuisance value, it doesn't take away your life. And hence, to answer your question, estrogen replacement therapy or hormone replacement therapy is almost not used anymore, or used in a very small select group of people who have early hormonal deficiencies, merely because the risk of cancer has increased dramatically if you're on this therapy, and hence we don't use it anymore, though logically it should be the right approach.
Next question from Mukund. How you treat delayed union of fracture in osteoporotic patient?
So again, this is a bit off-label, but most orthopedic surgeons have started. Though personally, I do only spine surgery, but I can answer this question, on the behalf of orthopedic surgeons. That if you know that this is an insufficiency fracture, an intertrochanteric fracture, a spinal vertebral fracture, which has happened with an insignificant trauma, a small trivial fall in the house. The patient is a 70-year-old, or basically it fits in the profile of osteoporosis. When you fix the fracture, there's a high chance that it's not going to unite because bone formation is not happening. So most of us, other than fixing the fracture, would want to add a lot of bone graft, would want to either the alignment of the spine, or the of the bone that is to be fixed. So the loads on the fixed fracture, the biomechanics is favorable, and more importantly, back this up with bone forming treatment. So almost all our patients who have a non-union or even a fresh case of an insufficiency fracture, we would back them up with at least a year of teriparatide injection, and that will reduce the chance of non-union. If there is a non-union, you would be able to heal it. Specific to non-union, we nowadays also use bone morphogenetic protein intraoperatively, which is a chemical which is been extracted from bone forming cells, and that can rapidly cause union in a non-union in an osteoporotic fracture. But I think the first choice would be to give teriparatide for a year along with your surgery.
Next question from Mukund. Will you prefer relaxofen over biphosphonate in post-menopausal women suffering from mild to moderate osteoporosis?
So, because I think the question is relevant, but most of us have not been using raloxifene, because when you see head-to-head trials in early postmenopausal osteoporosis, bisphosphonate still seems to score better. I'm giving you a bit of a biased view because I'm talking of spinal osteoporosis, because that's what we treat. And most trials that have been done for vertebral osteoporosis suggest that bisphosphonates do better than raloxifene, and hence, basically, we don't prefer raloxifene. We rather give bisphosphonates.
Next question. From what age does Indian population experience osteoporosis as compared to the West?
Again, this is going to be a speculative answer because we don't unfortunately have data. But as I mentioned before, I think perimenopausal, so around the age of 50, if you wanted a figure, is roughly when you would start, getting your antennas up to look for osteoporosis. In practice, we find, yes, it's roughly the same age group as you see in the Westerners, but deep down we feel somewhere that the age group could be much earlier. If we really started doing studies, there's a higher chance that we'll find earlier osteoporosis in Indians because of a variety of reasons. I think the lack of sporty habits in childhood, a large proportion of our population being vegetarian. I'm a vegetarian, and so there's an inherent deficiency in calcium and in proteins in our diet, and of course lifestyle. I think a combination of this. There's so much diabetes and so many other lifestyle conditions in India. I think if we really do a population survey, which we've not done, we might find that osteoporosis hits Indians early. But currently, the answer would be that it's roughly the same age group as we see in the West. Off and on, once in a way, we find, like I mentioned, a young osteoporotic. And when I discuss this with my Western counterparts, they seem to not find these young osteoporotics. So, a 35-year-old man comes saying that everything is hurting and I've done all tests, MRI is normal. They're finally referring me to psychiatrists, and I'm not depressed, but I'm taking antidepressants because my bone pains just don't go away. And you kind of get into his history, and you get a bone density test, and you find that it's at minus 2.5 for a 35-year-old male. And here, again, off-label, without any, any good practice guidelines from anyone, I have been using, or many of us have been using bisphosphonates in these patients, and especially the males, because bisphosphonates are not well used in women of childbearing age group. It's contraindicated. So we use bisphosphonates for a short course, and we find dramatic clinical recovery in such patients.
Next question from Vishal. Who should be treated with spinal osteoporosis medications? Second part, what are the choices of osteoporosis medication?
So normally, as a part of our, kind of wholesome treatment, so any person with a lumbar stenosis or with spondylolisthesis, who fill in our OPDs, right, with back pain from a disc or a degenerate disc, if they belong to an age group or they belong to a clinical profile where osteoporosis is likely, we preemptively ask for for tests to prove or disprove osteoporosis as a separate part of treatment. So, for example, a 70-year-old lady comes with lumbar stenosis, saying that when I walk, my legs claudicate. Other than MRI and X-rays, I would ask her for a DEXA scan, and whether she chooses surgery or injections or just rehab, we still would give her anti-osteoporotic treatment, because osteoporosis is not merely bone loss, it's also muscle loss, so sarcopenia. And when you put a spine patient on rehab, if his muscles are poor, so if there's a poor muscle mass because of osteoporosis, the chances of this rehab working are much lower than otherwise. So to cut a long story short, almost every patient who's in the age group of osteoporosis who comes to you with any spinal ailment, I would look for osteoporosis and treat it with the relevant medications. As far as which medicines go, the answer would be that roughly if it's very deep osteoporosis and very symptomatic, so someone who's got a fracture which is not healing or which is causing a lot of pain, and the person's DEXA scan is like -3 or -4, I would target to treat him with teriparatide, at least for 1 year, if not for the whole 30 months at one go. And this I would do by first checking his calcium levels, his PTH levels, asking for a history of cancer, and probably checking his P1NP also. Others who come with mild to moderate pain and earlier symptoms, younger age group, with a DEXA closer to -2 or -2.5, I would start them off with bisphosphonates, monitor them yearly, and at some point maybe give them a switch to teriparatide.
Next question. For spine BMD improvement, which is the most preferred biphosphonate?
So alendronate scores over residronate amongst bisphosphonates. So residronate is a newer pill, but in all the studies for spinal osteoporosis, alendronate scores better than residronate. So the answer to your question is I would give alendronate 70 milligrams once a week. Again, once a week oral tablet has the best results in studies, and hence I do not like to give a once a month tablet or a once a year injection, and I'd give once a week, 70 milligrams of alendronate for spinal osteoporosis. That will show the best. That has the best likelihood of the DEXA improving.
Question from Shweta. What drug is the best for perimenopausal bone loss?
So perimenopausal bone loss we come back to all the answers that I gave some time ago. Between hormone replacement therapy, which is logically the right approach, but practically causes too many risks, versus raloxifene, which is in between. It's an in-between option, but it's not tried and tested, so to say. It all boils down to anti-osteoporotic, means bisphosphonates. So perimenopausal osteoporosis, I would still ask for bisphosphonates as the first choice of drug. But when we are giving this therapy, simultaneously you want to tell them all the other things involved. So you want to tell them to increase their bone mass by exercise, especially in Indian women, to do upper limb exercises which they lack. So if you do a plethora of DEXAs of 50-year-old Indian women, you'll find that their forearms seem to score the worst compared to hips and spine. So you make them do exercises for the upper limb, tell them that walking is important, give them the importance of calcium and proteins, especially in the diet, and the importance of regularly monitoring osteoporosis. So it's not something that happens during menopause, it's something that starts off during menopause and happens throughout life. So every year they're only going to get worse. So in short, a lot of counseling other than the medications is important, and the drug of choice for me is still bisphosphonates.
Next question from Prerna. What are the major causes for spinal osteoporosis? Please suggest some precautions to avoid the same.
So major causes of spinal osteoporosis are the same as the causes of osteoporosis. So in your young age, just to put it very simply, in a young person, during young age, if he's not been active, not been loading his back, he's eating poorly, not eating enough proteins or calcium, not being exposed to adequate sunlight and ultraviolet light more than sunlight, because sunlight gets filtered in smog. So in an urban dwelling, a child playing out in the sun need not still get his vitamin D dose from the sunlight. That sets it up. Then if there's a genetic predisposition, if there's a history of osteoporosis in the family, or if he's bad genes, and then from a woman who has osteoporosis, that osteoporosis will pass on to the daughter. So that sets it up. So these people are more likely. Normally, however futile it sounds, by the time you're 45 or 50 years old, it's already written on your spinal kundalini, if you may, that you're going to end up with osteoporotic problems in the spine or not. Because if your bone mass is good at the age of 50, you're going to very slowly taper down as the years go. If the bone mass is poor, no matter how healthy you convert your lifestyle to, you're going to quickly reach that critical bone mass and start getting fractures. Once you have spinal osteoporosis, the earliest sign is bone pains and early kyphosis. And this, as a doctor, you got to recognize and preemptively treat these people. They may come to you for something else, knee pain, anything. But once you see a profile of this person, you ask them for loss of, mass. You say that their muscle mass is reducing, their capacity of working is gone down, they get tired early, they get pains, they are tender all over. And you quickly, jump on this and try to figure out the osteoporosis and then treat it, because that will then take care of the problem. So that's how you manage spinal osteoporosis.
Next question from Vishal. Does a minor fracture now can make the chance for a later reason for the severe osteoporosis?
So I would take your permission and frame the question in another way. A fracture does not lead to osteoporosis, but osteoporosis leads to a fracture, and what we call a minor fracture. So patient comes saying that there's a small crack in my bone. Especially if that small crack is in any of the weight-bearing long bones. So if it's in the shoulder or if it's in the hip, even a small crack is a big fracture. So typically a small fracture happens in the spine where the spine just collapses. One of the vertebrae just collapses and the person gets pain and then the fracture heals. Now, once he gets a crack without a major injury, like for you to get a small or a young person to get a small crack, you should really have a major vertical trauma, like a car accident or a fall from 2-3 floors height. If this guy has had this small fracture, just stumbling off the stool in the house, this should be the harbinger, red flag for you to label this guy osteoporotic and give him the best available treatment, most likely teriparatide, and get on the right side of the osteoporosis. So to cut a long story short, if it's a minor fracture, the fracture may be minor, but the osteoporosis is major. Full stop. No discussion. And the fracture will take its own course, but you got to treat the osteoporosis with a big fist, not with small measures, but go after it and get it eradicated, or treat it as good as you can in the first 1 year. That's the message. Yeah.
Next question from Bibin. Does the 4-biphosphonate ibandronate also irritate the esophagus similar to oral BPs? Are there any tests or screenings available to identify who might be more susceptible to the side effects of any of the osteoporosis drugs?
So again, two parts of the question. I'm not sure if I'm well qualified to answer this question. It's a good question, but I'm still going to tell you my bit that oral anti-osteoporotics have the problem of, or oral bisphosphonates have the problem of causing hyperacidity. The way it goes is that when you take an anti-osteoporotic tablet, if it hangs around in anywhere between the esophagus and the stomach, it will cause a lot of acid reaction. And hence it's important that this tablet quickly goes through the esophagus, stomach into the duodenum where it's alkaline, where the conditions are alkaline. And hence this requirement to have this on an empty stomach, because the gastric turnover time is very quick when the stomach is empty, while if there was food in the stomach, the tablet would hang around. It's important that you don't take anything after that until the tablet goes past the barrier of the stomach. And it's important that you don't lie down, so you expedite the process of the tablet going through across the stomach into the duodenum. If this happens, you don't get hyperacidity with these tablets. So if your patient is getting hyperacidic, you ask detailed into the way he's taking the tablet and make sure that he's taking it correctly. In the group of people who do get hyperacidity with the oral tablet, we normally like to give them strong antacids the night before. And I don't think it comes in the way of absorption, though again, I'm not so well qualified to answer your question. Injectable anti-osteoporotics don't have this side effect, clearly, because there's no oral stimulus of to the mucosa or to the gastric mucosa of the drug. But they have so many other side effects, like almost every patient gets a flu-like syndrome. And sometimes, I mean, it's so common that they need hospitalization during this injection that personally, if I was the patient, I would rather choose acidity over this, huge 2 days of side effects of injectable anti-osteoporotics. And I would, rather take once a week tablet, and that's what I do for my patients. As far as predictability goes, I don't think there's any way to predict the side effects of anti-osteoporotic drugs, like who's going to get it and who will not. So it boils down to monitoring, and you monitor them closely. For example, if your patient says that you write him the drug and he says, "Okay, boss, I feel acidic with even crocin," you kind of, look at them more seriously. You ask them to call back after their first few days. You warn them that their first few outings with the drugs may cause increased acidity, or maybe preemptively put them on antacids. On the other hand, if someone's on teriparatide, you want to monitor calcium, especially people with renal problems. You want to make sure his PTH and calcium levels are in control, because hypercalcemia can be a side effect in a select set of individuals. You cannot predict beforehand, but you want to at least monitor it.